Dear friends, welcome back to today's session. So we'll wait for another 2 minutes and then we'll start.
Anandji, am I audible?
Yeah, you're audible.
Okay.
Okay, good afternoon, friends. We'll start. Today we have again interesting sessions. So the topics will be starting with the first. We'll be having a talk on rational use of vasopressors, like as requested by our viewers. Followed by we will be having a simulation. Today we have a different type of simulation. We have seen ventilator simulation so far. So today we'll be having a hemodynamic simulation where the different scenarios you can see like in the monitor, what is happening to the ECG, heart rate, BP, and accordingly we'll give you the other scenarios also. So like as we did yesterday, like a few of you will have to come to the panel list and like you can suggest what the treatment like has to be done. So different situations we will discuss, and all the things will be discussed before in the lecture itself. After that we'll debrief and see, like after each session we'll debrief and see. Probably it will take another maybe 30 minutes more. So altogether that will be 1 hour. Followed by we will be having Dr. Fabit's session today. It's very interesting. Like he'll be talking on the cardiac evaluation, especially echo, the different scenarios, and again he will give you the simulation images as well. You can again interpret and come to a clinical diagnosis. So that is our plan. So Fabit, I have already introduced you, and again he is very familiar to you now. So now I'm having another extremely good faculty with me. He is Dr. Saneesh. He is a consultant in anesthesia and critical care in Anandapuri Hospital, Trivandrum. And a few more things to add. Like in my WhatsApp and Facebook, so many people are commenting saying that, Doctor, your slides are really good, and the presentation is okay, all those things. And whatever slides and animations I've learned, all these things from Dr. Saneesh. He was my teacher in Kasturba Medical College, Mangalore, when I was doing MD. So I did my MBBS in Calicut. We were not having any exposure in PowerPoint and presentations. So whatever I learned and whatever I am doing now, everything is I learned from him. Even now, like when I do presentations, he observe and give me positive feedback. So he's an excellent speaker, and he is having many academic activities as well. So he will also continue with us in the coming sessions. So welcome, sir. You can continue.
Thank you, Anoop. I thank all the organizers, Dr. Fabit, Dr. Anoop, for giving me this opportunity. I know many of my friends are watching. Very good afternoon to one and all. Today's topic, we have decided it's inotropes and vasopressors. And when do you make a rational choice of inotropes and vasopressors? Okay. The moment you enter the critical care postings, these are the terminologies which might give you a feel that it's a difficult scenario. And for this discussion, we'll stick to the basics. And once the basics, fundamentals are through, probably we can negotiate through the remaining part of the advanced decision making and all. Okay, the first step to know how to choose your vasopressor or inotrope is to know the basics. I'm not going into the basics. I expect all the delegates to know what is shock, where the tissue perfusion suffers, what is cardiac output, stroke volume, about systemic vascular resistance you should be knowing. Preload is the initial load with which the heart starts to pump, and afterload is the resistance against which the pumping action happens. And the decision on whether to start on inotropes, whether to choose vasopressors, depend on the background conditions. You should know the clinical features. You should have a working diagnosis. You should have an idea what exactly is probably happening in our patient. The pathophysiology is important. Yes, monitoring. Nowadays, we are into software dependent, sophisticated monitoring. So many intensive care units, we have a whole range of advanced monitors, invasive and non-invasive. Our equipments will determine how precisely we can take decisions and arrive at a conclusion or a diagnosis. And of course, the availability of drugs. If you don't have all the drugs available and you have one or two, your decision making actually becomes easier, because critical care is all about maintaining the physiology as much as possible and maintaining the life, maintaining the hemodynamics, maintaining the oxygenation till the primary condition resolves. That will take its own time, or you can expedite the curing of the primary condition. Till then, there should not be any end organ damage. That's our key aim in maintaining the hemodynamics. Going back to fundamentals again, you should know the volume status. We should know whether the patient is volume depleted, or actually in a case of pulmonary edema and kind of cardiogenic shock, whether we have to diurese the patient and reduce the volume status. And some of the drugs we are using for inotropes, vasopressor, that category, they act on many receptors. For example, dopamine might act on dopamine receptors per se, and of course, catecholamine receptors like alpha or beta receptors. Dose response curve. This is again a tricky one, because whatever dose response curve you expect in a physiological condition may not be the curve when you deal with the same patient with sepsis or with vasoplegia. The dose response curve actually is totally different. So it's all about titration, iteration, and finding out the best dose and or best combination that can do the best for your patient. Again, you should try to delineate or demarcate between the direct actions of the vasopressors and the reflex actions. Okay, starting from basics. When somebody is in shock, most of the time blood pressure falls. And how does hypotension present? It may be due to a very low systemic vascular resistance or loss of arteriolar tone, or cardiogenic effects, low cardiac output. Both these divergent scenarios can lead on to hypotension and eventually culminate in shock. And when there is inadequate SVR due to pathological vasodilatation or vasoplegia with a compensatory elevated cardiac output, we get into a scenario called warm shock. At the other extreme, when the cardiac output is inadequate, body is trying to constrict all the arterioles, elevated SVR, compensatory vasoconstriction at the maximum, you get into a scenario called cold shock. And in actual life, the moment you start fluid resuscitation, it can get shifted to a warm condition, or warm shock with myocardial dysfunction can switch over to cold shock. So the scenario is going to be dynamic. Your morning diagnosis may not hold true by afternoon or evening. Things can change very fast. We'll see what happens in warm shock. There is increased compensatory cardiac output, so the pulse pressure may be preserved in warm shock. SVR is reduced due to profound vasodilatation, so we get a good palpable bounding pulses and warm extremities. So here we can arrive at a conclusion that we are dealing with a vasodilatory or distributive shock. The other extreme, cold shock, where cardiac output falls, we get weak distal pulses, the pulse pressure narrows, and for profound vasoconstriction, it will lead to cold, clammy extremities. This can occur in hypovolemic shock or obstructive shock due to inadequate preload or impaired cardiac contractility, as we get in scenarios like cardiogenic shock. I hope everybody is following. And now we'll keep things simple. You can see the heart there. Beta 1 catecholamine receptors, they are responsible for the force of contraction, inotropy, rate of contraction, chronotropy, right? Coming to the arteriolar and vascular and beta 2 receptors,
Really sorry for that issue. There is some problem with the network. He'll be back soon. Sorry for that. So there is a network issue nowadays. The network has so many issues, especially the traffic is more and the speed is really compromised. That's why. But he will be back soon. Okay. And again, we have many simulations as well. So what we'll be doing today is we will show you the monitor where you can see the ECG like SpO2, like other BP options, like just like our normal monitor. So you will have to set in the monitor like what all the things are has to be set. Then after that you can suggest the drugs or the fluid, or if you want something else like blood or blood products. Then we will progress the things slowly based on your treatment. Then after that, we'll be having a debrief. So I want all you to actively participate. That is how we will learn. So those who actually wanted to join us for the discussion, they can raise the hand and we can start that part. So we will just wait for a few seconds for Dr. Saneesh to start. Then again we will go back to the monitor. Okay. So the situation will be like I'll just show you how we will be doing the things. Just 1 minute. Just trying to. Just 1 minute. I'll just show you how the thing. So this is the feel you will be having. So this is our first patient. You can see what is happening, like what is the heart rate, what is the BP, and this is not like yesterday's simulator. This is a actual simulator where you can see exactly what is happening. So Dr. Saneesh is back. We will again start that later. What happens, sir? What was issue? You will have to unmute yourself.
Power failure.
Power failure, huh?
Ah.
Yeah, okay, okay. You can start. No problem.
Hello?
Yeah, you can start.
Is it visible?
Yeah, yeah,
Screen is visible?
yeah.
Sorry for the interruption because there was a power failure because of the bad weather conditions. Okay, so we are dealing with a simplified thing now. The heart with beta 1 receptors dealing with inotropy and chronotropy. Beta 2 receptors at the arteriolar end causing vasodilatation. Alpha 1 at the venous end supporting the venous return. Now, here is the broad classification of the drugs we are dealing with now. Actually, in the top down left column, we'll find an alien group called vasodilators. Okay, we'll leave that. Coming to the direct inotropic effects.
Sir, you will have to share the slides.
One second. Visible now?
Yeah, yeah.
Okay. So we have 4 categories of drugs. Only the one on the lower left column doesn't belong to our discussion today. These are vasodilators. So right half we have drugs with direct inotropic effects. And if you see, there are drugs with only inotropic effects with some vasodilatation in the lower part, and inotropic drug with vasoconstriction, vasopressor activity in the upper half. The ones with vasoconstrictor activity and inotropic activity are called inoconstrictors, and the ones with vasodilation property along with positive inotropy are called inodilators. Coming to the next group, vasopressors, whether there are only vasoconstriction, they are called vasoconstrictors, and those with vasoconstriction and inotropic action, they belong to inoconstrictors. Now let's find out who all are there in each group. Inotropy and vasoconstriction, our favorite drugs, norepinephrine, epinephrine, and dopamine. Pure vasoconstrictors, phenylephrine, vasopressin. Inotropes with vasodilation properties, dobutamine, milrinone. And of course, the left out part, pure vasodilators, include nitroglycerin, nitroprusside, neseritide, etc. Coming to catecholamine receptors, I have tried to place these drugs in the proper positions. In the left side of the screen, you will see more of alpha receptor predominant action. Right side, you will see more of beta receptor predominant action. So where does epinephrine or adrenaline go? It has both alpha and beta action. Next one, phenylephrine goes to the alpha extreme. It's more predominantly alpha only. Dobutamine more towards beta receptor side. Isoproterenol much more beta specific. Norepinephrine more towards alpha adrenergic receptors. This is a tricky one, dopamine. In lower doses, it acts on dopamine receptors and then beta receptors. Only in high doses, it changes its side towards the alpha. So my request is to keep this picture in mind. From the mat, we have picked up our drugs which we are likely to use today for our discussion and our case scenarios. This is the order. When you want a predominant alpha action, choose from the alpha side. Predominant beta action, go to the beta side. And in between, whenever you are choosing drugs, you have to keep in mind there will be a bit of alpha action and a bit of beta action. More scientifically correct will be plotting these drugs in this graph. Here, as we go on the positive side of y-axis, the vasoconstriction property increases. As we go towards the right extreme, the inotropic action goes up and up. Of course, if you go down the axis, y-axis, the vasodilatory property appears. Norepinephrine slightly towards right, but more towards the vasoconstriction action. Low dose of epinephrine or dopamine, we have come right across to the positive inotropic side regarding vasoconstriction, only a little bit above the baseline. When you go to high dose dopamine, the increase in inotropy is marginal, but it becomes more significantly vasoconstrictor. High dose epinephrine, again you travel rightwards and upwards. So more of vasoconstriction and more of positive inotropy. Phenylephrine will not move along the x-axis at all. It is highly vasoconstrictive. Our other friend vasopressin is also placed somewhere close in the y-axis. It has only vasoconstriction action. Dobutamine for a change falls below the baseline. So that means it causes vasodilatation. But if you look at the inotropy side, it has come all the way to the right side. So it has positive inotropic action and vasodilatory action. To take nitroprusside, NTG and all, it will cause only vasodilatation. So it will not move rightwards, it will move only downwards. So once you have this picture in mind, any clinical scenario, we choose drugs from a particular area. Say for example, if you want more of vasoconstriction, choose from this area. We don't need to play around with the inotropy at all. You choose this area, phenylephrine, vasopressin, norepinephrine, okay? If you just need more of inotropy and you don't want to increase the afterload much, then you can choose dobutamine because it's not going to increase the amount of vasoconstriction, it causes dilatation. But again, yes, in cardiogenic shock, there is a possibility of BP dropping after dobutamine. Okay, then you can choose the other ones depending on your requirements. So basically, if you keep this picture, the graphical representation in mind, then your decision making will be more or less easy. So this is the method that we are trying to discuss today. How do I make my choices? Is it depending on the receptor action or agents? We are jumping around. Now we are going to select based on the effects. Ultimately, that matters. If you need to bring the heart contractility more, you choose on more of the right side, positive inotropy. If you want more of vasoconstriction to maintain the perfusion, like in traumatic brain injury, you go upstairs. Try to choose something from the positive y-axis or vasoconstriction axis. So your choice will be something like vasopressin, phenylephrine, or norepinephrine. The choice between these agents will be largely evidence-based. There is nothing much to choose. If you don't have one drug, forget about it. You can use the nearest possible choice. So how do we make a choice? If you need a vasopressor, vasoconstrictor, your idea is to restore adequate blood pressure, you choose a vasopressor. But remember, BP does not always equate to blood flow. Next, if you want to choose inotrope in your armamentarium because you want to increase cardiac output, again keep in mind that to determine whether cardiac output is adequate in patients with shock is a difficult question. So these are the points we need to keep in mind before proceeding. When there is hypotension, the perfusion pressure suffers. Most of our end organs are in danger. There is every chance of abnormal shunting of blood flow within organs. And there will be cellular alterations so that there will be inability to use delivered substances. And of course, you need to keep in mind the down regulation of Just because you flush in catecholamine agonist, things work. In that case, you have to find out some catecholamine sparing drugs, and you can again. Am I still on? Okay. So these are the things that we need to keep in mind. So how do you take a decision? The first and foremost, when patient is hypotensive, is you should have an idea about the patient's volume status. So now you know the present practice of IV fluid infusion and fluid boluses, whether it's crystalline, colloids, whether you can give blood. These are all subject to debate depending on case-to-case basis. There comes the importance of having monitors. Some of the monitors, of course, I agree, they are surrogate monitors. They may not actually reflect the things, but we don't have an option but to depend on the monitored values. Say, for example, non-invasive blood pressure, central venous pressure. If you don't have a cardiac output monitor, we have to rely on these things. And probably the trending of these values will help you much more than the absolute values. And then, of course, depending on the scenario and how you think the pathophysiology is playing around in your particular patient, you decide whether to choose for a vasopressor or inotrope. So your target is to restore effective tissue perfusion and normalize cellular metabolism till the primary disease gets cured. Okay, whether it is myocardial dysfunction or frank sepsis, until sepsis recovers, you don't want to leave the end organs to inadequate perfusion. So the decision-making point, which one works? What is the sequence? What first? What comes second? You should have some idea about how this drug works and what are your goals. What you are trying to achieve is more important. And you need to consider the best available clinical evidence, especially when you have more than one options playing around. When you have invasive monitors, things are more easier, sometimes complicated also, because you need to play around with a lot of values like cardiac output, stroke volume variation, cardiac index, SVR, and things like that. But here, for understanding purpose, initially I have selected 3 or 4 scenarios, and I will explain how we take a decision or what is the recommended choice of inotrope or vasopressor, so that you will be groomed into that decision-making mode. And once that is done, we go into the actual and entertaining part of today's discussion, that is simulation-based practice of our decision making. So first scenario we'll do on cardiogenic shock complicating acute myocardial infarction. So my humble request to the residents listening to this webinar is, you need to understand why we come to this particular scenario rather than taking a cookbook recipe kind of thing, that this condition, this is the drug. No, it will not work like that. So basically, once you get the fundamentals through, and as and when evidence appears, we can refine our practice. Critical care is all about refining our practice based on the evidences. Now, our patient is in cardiogenic shock following acute myocardial infarction. So the perfusion pressure has suffered. There is critical hypotension. Now there is question whether to add inotrope or vasopressors. So what are the balancing thing? Once we add catecholamine or non-catecholamine drugs, there is every chance of inducing ventricular arrhythmias. The heart might contract more. It's already ischemic. You can cause contraction band necrosis, and even infarct expansion is a possibility. We have to consider that. But then you need to keep in mind that the compromised myocardial perfusion, the elevated LV filling pressures, further reduction in coronary perfusing pressure, CPP, all are going to make the condition worse and worse and worse for your patient. So now you have to take a balanced decision. Your first target will be to maintain the coronary perfusion pressure rather than aiming for your blood pressure values. So what is the need of the hour? The heart is not contracting, the contractility is compromised. Can we do something to increase the contractility? So shall we move towards the right side in search of some drug which will increase the pumping activity of the heart? And first we see dobutamine, which will cause inodilatation. That is, vasodilatation is a side effect, but actually it will not add to the resistance against which the heart is going to pump. So it might be a good choice to institute dobutamine. Again, the other choices are in and around. What about dopamine? Dopamine is also a good choice. So we go to the recommendations. See the AHA, American College of Cardiology recommendations. In a case of cardiogenic shock, say systolic blood pressure varies from 70 to 100 millimeters of mercury. So the recommendation is when there is no signs and symptoms of shock, you can choose dobutamine. It seems to be a good rational choice. But if there is signs and symptoms of shock, your choice switches to dopamine. You know the previous diagram, these are actually up and down in the positive inotropic axis. So moderate doses of these agents maximize inotropy and avoid excessive alpha-1 adrenergic stimulation that can result in end-organ ischemia. So these are the scenarios where when we are given with two similar choices, you decide based on the evidence. Now the issue with our residents is how do we make dilute the drugs? How do you prepare dobutamine? You cannot just tell your ICU nurse, please start on dobutamine. You should know what is the preparation available. You should know what is the loading dose. How do you titrate the dose? Fine. So dobutamine in our place, it's coming in 250 milligrams per 5 ml ampule. And we need to start without a loading dose at a rate of around 3 to 5 mics per kg per minute. So our stable dose is going to be somewhere around 5 to 20 mics per kg per minute. Okay. Now, how do you tell the anesthesia nurse or critical care nurse to prepare the drugs? Or if you happen to prepare the drugs, how do you prepare? Okay. Now we have dobutamine 250 milligram in 5 ml. You draw it in a 50 ml syringe. The diluent usually we take is 5% dextrose or NS. So diluent drawn to make the total volume as 50 ml. Follow? So now we have 250 milligrams of the drugs dobutamine in 50 ml. Solving it, we get 5 milligrams per ml. That is 5,000 micrograms per ml. That is the strength of the diluted dobutamine. And suppose our patient is a 50 kg patient. Eventually we need the dose in micrograms per kg per minute. So 50 kg patient, this 5,000 mics divided by 50 mics per kg per ml, it comes down to 100 microgram per kg per ml. Hope we are following. Now we'll see the infusion rate. How much is 1 ml per hour? So 1 ml we know is 100 mics per kg per ml. So 1 ml per hour is 100 mics per kg per hour. 1 hour is 60 minutes. So solving it, we'll get 5 by 3 mics per kg per minute. I think it's simple arithmetics. So rather than making it a divided decimal point, a good practice is to maybe take the 3 from the denominator to the left hand side. So 3 mLs per hour is equivalent to, or it gives 5 mics per kg per minute. Okay, so dobutamine in this dilution for 50 kg patients comes down to 3 ml per hour equals 5 mics per kg per minute. So if you want to start at 3 to 5 mics per kg per minute, you can tell the nurse that you start at 3 ml per hour. We'll see the response and up titrate depending on the response. Clear? So all the infusion pumps should have a good label mentioning the proper chemical name of the drug, how much amount is taken, how much is the total diluent volume, and the date, time, and who loaded this. So everything should be accountable in the label. Most of the institutions have a printed infusion drug label, I believe. If you're choosing dopamine, how are you going to prepare it? Dopamine comes in 200 milligrams in 5 ml ampule. So low doses, previously we used to call it as renal dose and all. So 2 to 5 mics per kg per minute. Then we up titrate. The usual dose range is going to be 3 to 10 or 3 to 15 mics per kg per minute. So how do we dilute? Again, if you take 1 ampule, 200 milligrams and dilute, make to 50 ml. Now we have dopamine 200 milligrams in 50 ml. So reducing it comes down to 4 milligrams per ml or 4000 mics per ml. Again, we take our 50 kg patient, 4000 mics per divided by 50, that much microgram per kilogram per ml. Comes down to 80 mics per kg per ml. Again, infusion rate, we should know if I am giving 1 ml per hour, how much is the mics per kg per minute. So 80 mics per kg is 1 ml, 80 mics per kg per hour is 1 ml per hour. Converting hour into minute, it becomes 4/3 mics per kg per minute. Rather than writing it as 1.33 mics per kg per minute, you can also write as dopamine 3 ml per hour is 4 mics per kg per minute. If the patient was around 65-70 kgs, probably we can come down to maybe 1 ml equals 1 mics per kg per minute. Okay. So usual dose range is 3 to 10 or sometimes 15 mics per kg per minute. But now the scenario is slightly more complicated, where cardiogenic shock with after MI is giving a systolic blood pressure of less than 70, and with our dopamine or dobutamine or combination of both is not working. So there is extensive reduction in SVR. So we need to bring up the systemic vascular resistance. We need to add something which will constrict the vessels. So there is none better than our favorite norepinephrine. It has also shown to have some antithrombotic effects also. And some people studied using high dose of epinephrine in this scenario where cardiogenic shock after dopamine or dobutamine, blood pressure is still not improving. High dose epinephrine, it was shown to have some negative effects, like it is shown to promote thrombosis in the coronary vasculature, and it has also been shown to exacerbate the lactic acidosis because of the extensive distal vasoconstriction. Another choice will be vasopressin. Vasopressin is a non-catecholamine vasopressor it is also shown to reduce the catecholamine requirement. In such cases, it's a good adjuvant, good companion, good Samaritan. It improves mean arterial pressure, improves cardiac index. LV stroke work is better. It reduces the norepinephrine dose and it improves the coronary blood flow, catecholamine sparing. That is the most significant advantage of vasopressin. Whoever is working in ICU, residents will get excited whenever they see severe sepsis or septic shock, right? So the guideline is surviving sepsis campaign. So what is the problem? There is extensive vasoplegia, extensive vasodilatation. So we need to have a strong amount of vasoconstriction. Okay, our choice is about adding a vasoconstrictive agent so that we'll maintain some systemic vascular resistance and maintain the organ perfusions. Okay, so vasopressor therapy is initially targeting a mean arterial pressure of at least 65 millimeters of mercury. By the time we should be able to sort out what exactly caused the sepsis, whether it is cellulitis, abscess. So unless the primary condition is corrected, your hemodynamics is not going to work. And one more thing, in the severe septic shock, severe lactic acidosis, acidotic medium, things are different. There is additional myocardial depressant effect of severe metabolic acidosis as well. So how do we make a choice? The recommendation says norepinephrine is supposed to be a superior choice. It improves the systemic blood pressure. It does not substantially worsen the end organ ischemia in most studies of crystalloid resuscitated septic shock patients. It has shown equivalent efficiency in maintaining the MAP, oxygen consumption, oxygen delivery compared to other catecholamine pressors. And actually gastric pH has been observed to increase after starting norepinephrine. So Surviving Sepsis campaign usually designates it as the first choice vasopressor. Norepinephrine, as you know, the usual dose is 8 to 10 mics per minute. The preparation, if you read carefully, it says 1 ampule of 2 ml contains 4 milligram of noradrenaline tartrate, equivalent to 2 milligrams of noradrenaline base. That means 2:2. 2 ml gives 2 milligrams of noradrenaline base. How do we dilute? We take 2 milligram in 2 ml norepinephrine base, diluent drawn up to 50 ml. Now we have a noradrenaline 2 milligram diluted to 50 ml. 2000 micrograms in 50 ml comes down to 40 mics per ml. Infusion rate 1 ml per hour is 40 mics per hour, 40 mics per 60 minutes. You can see the calculation 2/3 microgram per minute. So rather than making it a fraction, you say 3 ml per hour is 2 mics per minute. So mostly you can start at the single dose norepinephrine with 3 ml per hour, then repeatedly check the vitals, see the response, and go up by 2 ml per hour or 3 ml per hour aliquots. Epinephrine is another catecholamine vasopressor. Its preparation is 1 milligram in 1 ml ampule. Initially, we start with 1 to 2 mics per minute or 0.02 mics per kg per minute. Usual dose range is around 5 to 15 microgram per minute. How do we dilute? It's similar. We take 2 ampules so that your calculations are more easier. So it becomes similar to the calculation we did just for norepinephrine. So 2 milligram of epinephrine drawn up to 50 ml. So only the drug changes, the values remain constant. So eventually it comes to 3 ml per hour is 2 mics per minute. So you know how to start maybe 5 mics per minute or 15 mics per minute. One thing to note is there is actually no upper limit of dose. It depends on how desperate you are to maintain the vitals. And another dictum is rather than going up and up on one drug, there is always better to add a second one or a third agent so that there will be mutual sparing and mutual reduction in the negative effects of these high dose drugs. Phenylephrine is again a pure vasoconstrictor. Initial dose is 0.2 milligrams, which can be repeated in increments of 100 mics. Some books mention it can be infused at an initial dose of 0.1 to 0.2 milligrams per minute and then down titrate depending on the response. So severe sepsis or shock, we can choose low dose epinephrine or dopamine as well. The thing is when epinephrine is added to and potentially substituted with norepinephrine, when an additional agent is needed to maintain adequate mean arterial pressure, the end justifies the means. Okay, dopamine is definitely an alternative to norepinephrine only in highly selected patients. When you are worried about relative bradycardia or the risk of tachyarrhythmia is less, you can choose dopamine as well. Phenylephrine is a good choice because it has a good vasoconstriction properties, but it is not recommended in the treatment of septic shock per se, except these conditions. When norepinephrine is associated with serious arrhythmias. Second, cardiac output is known to be high and BP is persistently low. That can also happen. And third, as a salvage treatment, when combined inotrope vasopressor drugs and low dose vasopressin have failed to achieve mean arterial pressure target. These conditions, we can straight away go to phenylephrine as a choice. Vasopressin. Vasopressin, the dose is 0.01 to 0.03 units per minute. Okay, it usually is dispensed in 20 units per ml. We'll come to the dilution a little later. The third scenario is neurocritical care when we handle traumatic brain injury or acute neurological injury. Again, there is some literature discussing what should be the vasopressor of choice in acute neurological injury. Again, our target is to maintain the adequate coronary cerebral perfusion pressure. Our mean arterial pressure target is the most important thing in maintaining the neurological recovery and saving the penumbral regions from the infarct expansion or edema expansion. So we need to maintain, we need not play around with positive inotropy unless there is a extensive intracerebral bleed and all. So your choice comes from this zone: phenylephrine, vasopressin, norepinephrine. And these agents are shown to have advantages in specific populations. Although high quality clinical data are scarce, the available evidence suggests that norepinephrine should be considered as the vasopressor of choice when blood pressure elevation is indicated in patients with acute neurological injury. Vasopressin, I said it is coming in 20 units per ml ampule. The usual dose range is 0.01 to 0.04 units per minute. Vasopressin 20 units per ml is drawn into 20 ml. So the resultant volume is 1 units per ml. Sometimes if you get 40 units ampule, you can dilute to 40 ml so that the infusion will last long enough. So there is no question of reinitiation of the changing the syringes. Okay, so we got a solution 1 units per ml. Infusion rate is 0.01 units per minute. That is 0.01 units. We are converting to units per hour. It's 0.6 units per hour. So coming down, vasopressin, the nutshell, 0.6 ml per hour gives a dose of 0.01 units per minute. So when you are titrating vasopressin, you start with 0.6 ml per hour, then you jump to 1.2, 1.8, 2.4, like that. So that you will get 0.01 to 0.04 units per minute. The biggest advantage of vasopressin is sparing of catecholamine drugs. Scenario 4 is anaphylactic shock. We all know about what exactly is happening in anaphylactic shock. There is extensive vasodilatation and extensive leakage from the intravascular compartment. So drug of choice, clear, it's epinephrine. Epinephrine is potentially life-saving and it antagonizes the effects of released mediators and it maintains the blood pressure. One thing to remember is the epinephrine given intramuscular is short-acting. After some time, the mediators will last longer than the epinephrine. So you have to keep on watching, or you start intravenous epinephrine infusion, continuous infusion, especially when the intramuscular epinephrine response is very poor. Dopamine infusion also can be used. And problem comes when you face beta block patients or refractory shock following anaphylaxis. Glucagon is another drug we need to keep in mind. It has got both inotropic and chronotropic effects on the heart by increasing intracellular levels of cyclic AMP. It can also reverse bronchospasm. So there we come to the end of the first part of our session. So I remind you, this is not a cookbook type of recipe. These are the take-home points. Norepinephrine, we choose in an extensive vasodilatory shock scenario. Dobutamine, when you want to improve the mean arterial pressure due to decreased cardiac output and shock is caused by cardiogenic shock, dobutamine may be a good choice. And a combination of norepinephrine and dobutamine is preferred in vasodilatory shock with a decreased cardiac output. Epinephrine, as you know, it's mentioned in CPR. It's the second line of shock and line for shock, unresponsive to other catecholamines. And vasopressin is a good choice for a resistant vasodilatory shock. This is another key take-home point. Use of other catecholamines and modern non-adrenergic vasoactive drugs in shock remains with little evidence, because there are enough discussion and literature coming up regarding drugs like our phosphodiesterase inhibitors and all. Yes, take a note of this. Smaller combined doses of inotropes and vasopressors may be advantageous over a single agent used at higher doses to avoid dose-related adverse effects. So this is the key take-home point. Rather than our rational choice depends on the effects it is likely to produce, and the effects we have plotted in a graph in a scientific manner. Going upwards, vasoconstriction increases, rightwards, inotropy increases. Once you have this plot of the drugs, you know which area our given patient is suffering from. Then you pick one from that area, and if you know the dilution, if you know the dose, starting dose, see the response and titrate the effects. Now it's time to discuss, and I invite Dr. Anoop to introduce the simulator-based discussion, case discussion, so that we'll comprehend whatever I have spoken now in a better way, so that you can also put it into practice.
So, 1 minute.
Anoop, I'll introduce the case scenario, and then you can share your slide.
Yeah, okay. So basically what we are going to do is like we'll be giving a case scenario now. So you can see the scenario. So before that, I will have to include a few panelists. A few persons have already raised their hand. So just 1 minute. So there are a few people here. So 2 persons I am promoting now. One I will promote Dr. Joshua. Yeah, Dr. Joshua, you will be in the panel now. And again, I'll take Dr. Jagannath also. Dr. Jagannath, yeah. So now, 1 minute. Okay, participants. Sorry. Yeah, Joshua, just unmute yourself, Joshua.
Hello, sir.
Yeah, okay. Where is the other person? There is one more person I promoted. Dr. Jagannath, are you there? Dr. Jagannath, can you hear me? Dr. Jagannath, you will have to unmute. Yeah, you are unmuted now.
Yes, sir. Yes, sir.
Yeah. Okay. So now you can listen to the scenario. Okay.
Yes, sir.
Yeah. Others, please keep commenting in the chat in the chat and in the Q&A. So Q&A, whatever specific Q&A you are having, you can put that in the chat. Like if these people are like giving some like false things, or like if you feel you can do something better, so keep chatting. So in the debrief session, we'll take all your points. Okay. So those who are having the specific points, so please keep chatting as the discussion advances. Okay, sir, we'll start.
Okay, am I audible?
Yeah.
Yes, sir.
Perfect.
I think I'll read out a scenario. Okay, who is attempting the case number 1? Joshua?
Yes, sir. Yes, okay.
So you can read the scenario, I'll read it for you.
Okay.
And the bedside management, you can tell me, because I'll be simulating bedside nurse who will obey your orders. Okay, so you decide what to do next and how to do and all.
Okay.
And it will depend on your progress. The case progress will depend on what you see on the monitor. Okay. Your patient will be connected to the monitor, and the monitor will be available for you also to see. I think all the participants, delegates can see the monitor. Now you can see the scenario. After that, we'll share the simulated monitor there. From there, you infer the clues. If you want any clarification, additional information, you can ask. Either me or Dr. Anoop will help you. And
Yes.
Dr. Anoop will be the consultant, ICU consultant, observing your steps, how you manage the case scenario, how you carry out the management. And after the case scenario, we'll have a debriefing so that you can comprehend what best is done. Sure.
Yeah. So, Dr. Joshua, what you have to do is like whatever things you are saying. Suppose you want to start vasopressing. So I see this. This is a situation. So I would like to give vasopressing. So try to give a short explanation and tell your bedside nurse what drug you want. So whenever you want the drug, also try to say like this much ambulin, this much fluid, and start at what rate. Okay.
Okay.
Then at the
Okay.
same time, you can see the monitors. So please see the monitors. So any extra things you want to connect in the monitor, do something and not, you will have to tell, or like what access you are going to put, or like you want to do some new investigations. All those things you have to ask. Okay, if you have any new investigation, if you ask your bedside nurse, she will do the test and she will let you know what is the investigation. Okay.
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 Yes, sir.
So we will start.
Okay, here comes the scenario. It is a 64-year-old male who comes to the emergency room because of nausea and 2 episodes of vomiting large amounts of dark brown liquid and complaints of extreme weakness. He also reported dizziness when he stood or sat up abruptly. You can see the picture, it's a pictorial one. On examination, pallor plus, your patient is diaphoretic. You connected the monitor, the heart rate is 128 beats per minute. Blood pressure right now is 88 by 54 and saturation is 96%. The scenario is clear. Somebody coming
Yes,
with
sir.
nausea, dark brown liquid, and he's having clinical symptoms of dizziness. Okay, now
Yes, sir.
we'll see the monitor.
Yeah. Okay, 1 minute. Joshua, now the patient. Yeah. So Joshua, I think now you can see the monitor.
Yes, sir. I can see.
Okay. So this is the vitals. It's connected.
Yeah.
And volume.
So the patient is in the emergency room. You can start managing the case.
Okay. So the patient is having severe pallor and he's tachycardic and the BP is also on the lower side. So I suppose that he's going into an hypovolemic shock. He's having GI bleeding since he has vomited dark brown blood in his vomitus. So I would like to, I would ask the sister to put a 2 large bore IV cannula so that I can instill fluids at a faster rate, preferably a 16 gauge in both the arms. And I would like to ensure that his volume status is adequate by giving 30 ml per kg of fluid boluses to maintain his uh, fluid volume. And I would like to take the blood along while installing the IV cannula to send for investigations, a complete blood count, the coagulation profile, and uh, and his liver functions also, along with PT-INR. And I would like to have a quick ABG to know the present hemoglobin level, and also I would send the blood for blood grouping and cross matching also. And by looking at the hemoglobin, if it is on the lower side, I would order for blood group and cross match, and I would order blood as soon as possible. Until then, I would like to load the patient with fluids, preferably 0.9% of normal saline. And hello.
Okay, doctor.
Yeah. Meanwhile, I will also start after. Yeah, yes, sir.
The secured one 16 gauge cannula, but I am unable to get a blood gas because the pulse is weak and steady.
Okay. Okay. Then we will, since he is bleeding, we will continue with the crystalloid resuscitation. Would like to give bolus of fluids, and
how much fluid you have to tell the nurse?
yes, sir. You can give 1 liter at present. The actual it is to be given as 30 ml per kg. We'll give 1 liter fast, and we'll look the response if the BP is improving and all. Fluid response I have to see. Still the BP is on the lower side, and
So we
patient is
have a
tachycardia.
warm IV fluid and room temperature IV fluid. Which one should I infuse?
You can give a warm IV fluid, sir.
You want to check the how much NIBP at what interval you kept?
BP should be kept at 3 minutes interval, preferably.
Okay, so you want to
And
keep it at 3 minutes? Okay.
interval. And if I can access an invasive blood pressure, that will help me to monitor the beat by beat variation in blood pressure. So I will try for an arterial line also.
You want an
Invasive BP
arterial,
monitoring.
you want
Yes,
an invasive meter. Okay.
yes.
We put an invasive
So
meter. Okay, your arterial line is in now.
okay. So the BP is slightly increasing with the fluid resuscitation. I will give more boluses of crystalloid, about 500 ml more, and I will as soon as the PRBC is available, I would like to start the start giving the PRBCs. And
Doctor, you want to give any consultations from emergency room? Any specialty
I would like to call the gastro medicine people for an emergency endoscopy if possible, and I will give a consultation to them. And the BP is slightly improving, and the mean BP is above 65. So I need not start the noradrenaline at present. I can manage with fluids, and I'm waiting for the PRBC. If I get it as soon as possible, I will install it at that moment itself. So his tachycardia is decreasing a bit. BP is improving. He is getting better and better. Can I have his SpO2? SpO2 is 94%. So I would also like to put a oxygen, give oxygen through face mask to maintain a saturation of about 97 to 99 at 4 liters per minute through face mask preferably. BP has started decreasing, and mean BP is below 65. So I would ask my sister to put a noradrenaline infusion, 1 ampule in 50 ml of normal saline. We can begin with 3 ml per hour at present. Meanwhile, I'm continuing with my crystalloid resuscitation. The BP is still, so I've started noradrenaline. I can increase the noradrenaline to 6 ml per hour now. I'm waiting for the blood group, for the blood. I'm waiting for the blood. If it is available, and I will install it at that moment.
Okay, fine. I have taken a blood sample.
Yeah.
I have drawn 10 ml. Which all labs I should send now?
It's an complete blood count, hemoglobin, platelets, a liver function to look for any liver pathologies, PT, INR, his renal functions, and blood grouping and cross matching already I have sent it.
ये live webinar चल रहा है.
How about serology?
ये
Serology also you can, sir.
2-3 सिटी में.
Okay, fine.
Yeah.
Then we will go for deep briefing.
Yeah.
Link नहीं तो Facebook पे
Okay. Yeah. Yeah, can you just unmute? Yeah. Okay. So this is the situation. You have seen. Anybody is having any like observations? How to titrate? Shall we start high dose and downtrade, or shall we start? So we are discussing about the situation now here. Since the patient is old age, we don't want the cardiac we don't know the cardiac status. So shall we give inotropes earlier? Okay. So that are the points. And in chats also there is vitamin K traffic. Yeah, there are many discussions are coming. Then hypovolemic shock, Rile's tube, somebody want to put vasopressin, PPI, source control. Okay. IV antibiotic, ultrasound. Okay. So now the situation is we had a patient with like you have already seen the situation, patient with a GI bleed presenting with a hypovolemic shock. So whenever there is an hypovolemia, your prime importance should be to correct the volume status. So you have correctly pointed out that. So if there is a hypovolemia, we will have to correct the hypovolemia, especially when there is a blood loss. Try to correct the blood loss. Okay. So one other additional point what you could have done is, like, especially when the patient is bleeding and again having hypotension, you have to always check for the coagulopathy. So whether the patient is having a coagulopathy, we will have to correct the coagulopathy also hand in hand. And hypothermia always will aggravate coagulopathy. So you should have asked your bedside nurse to put a temperature probe and monitor the like temperature. And if the temperature is low, we could have connected a like warming blanket or something like that. And another thing is like putting a Riles tube, giving a continuous Riles tube aspiration will give you a clue that whether the patient is having an ongoing GI bleed or not, or like any other you can also look for any other evidences of that as well. And if it is a GI bleed, you have to go hand in hand with other therapies, like you can start a tranexamic acid, or if it is a look for evidence of cirrhosis or something, in that case you can start using an octride or all things like that. Or if it is an ulcer bleed, like a pantoprazole infusion. And once the patient is stabilized, like unless and until you do a source control, you are not going to save the patient. So immediately as the BP started picking up, we should contact the gastroenterologist and should get the endoscopy done at an immediate point of time. And regarding the vasopressor of choice, here already the patient is having a tachycardia and a hypotension. All such situations, though, your first choice will be noradrenaline only. And again, we have already told how to start. Usually 2 ampules, that is 2 milligram, you add in 50 ml, then you titrate. You are in a critical care ICU. We are not much worried about what exact micrograms per kilogram per ml, all those things, because we want a target. So we look at the target, and up to usually we go up to 30 ml, 35 ml, like that. So in between, if the BP is not getting stabilized, you go for the second agent, like a vasopressin you can start. Even if that the patient is not improving, you go through a third agent, like a adrenaline. But always make sure in a patient who is having a volume loss, like stepping upon like the pressors, that is not the actual method of treatment. If there is a volume loss, you have to give the volume. And again, the volume responsiveness assessment you can do, like a pulse pressure variation in an arterial line, or this is not able to demonstrate in the simulation what we are having right now. Or like you can do a bedside echo, or like an IVC size, and you can make out that Dr. Pavid will be discussing those points later. So you have done very good, Joshua. Okay. So now, Dr. Jagat, are you ready? Jagannath, are you ready?
Yes, sir.
Yeah. Okay. So we will move on to next scenario.
Okay, fine. Thank you. We'll move to our second scenario. A 76-year-old gentleman comes to the emergency room with a sudden onset of chest pain and worsening of breathlessness, dyspnea. He has his previous history of CABG 20 years back with triple vessel disease and has noted features of progressive worsening of heart failure. His medications include tab aspirin, tab telmisartan, tab spironolactone, and tab atorvastatin. Okay, he was shifted to ICU for observation, but during his vitals check, he collapsed and became unresponsive. ROSC, or return of spontaneous circulation, was achieved after 4 minutes of CPR, 1 milligrams of epinephrine administered, and 1 shock of 200 joules was delivered during CPR. He was intubated and mechanical ventilation is initiated. Right now, neurologically, he is unresponsive. ECG shows STT changes with sinus rhythm, and heart rate right now is around 60s, 64 blood beats per minute. Arterial line is secured. Arterial BP shows around 80 by 50 millimeters of mercury with a saturation of 92%.
Okay.
Yes, sir.
So 1 minute, we will get the monitor now. Sorry, we are just connecting the monitor. Just 1 minute.
Okay, I'm briefing the scenario again. It's an elderly gentleman post CABG 20 years back with progressive worsening of heart failure, became dyspneic, came to the emergency room, came to ICU. By the time he collapsed. Okay, CPR was started. He was resuscitated in 4 minutes of CPR. Meanwhile, one shock of 200 joules and 1 milligram of epinephrine were given. During assessment period, he was shown to have a return of spontaneous circulation with STT changes in the monitor and heart rate of around 60. Arterial line is secured. His arterial blood pressure is around 80/50 times. So he is on mechanical ventilation now with a FiO2 of around 80%. He is able to maintain a saturation of around 92%. Okay. Dr. Jagannath, can you summarize the scenario? Like
Basically, this patient is elderly. Hello.
Yes, please go ahead.
The elderly patient with a past history of CABG now presented with acute coronary syndrome with cardiogenic shock.
Okay, fine.
With the post CPR status. Now he is on ventilator and in shock also.
Okay, fine. So what are your primary objectives now? What are you trying to optimize now?
I will optimize the hemodynamics of this patient initially because his BP is on the lower side, and I want to know the urine output of this patient also. You have not mentioned in the discussion about this urine output also.
Okay. He's just catheterized and it will take some time for urine to come out now.
Yeah.
Okay. And can we put the ETCO2 also?
Yeah, you want ETCO2 also? Okay, 1 minute.
It's around 28-30.
I want to optimize saturation also.
Okay.
So I want to know the ventilatory setting of this patient because saturation is hardly 90 he's maintaining and FiO2 of 80%.
Yes.
So basically I will ventilate with the slightly PEEP on the higher side.
Okay. How much PEEP you want to keep? And blood pressure is 50?
80.
Okay, that we have optimized. Saturation we have optimized.
Then I want to optimize the hemodynamics. I will, as the patient is in the cardiogenic shock, we will not be able to give too much fluid. So directly we will start on the pressors. I will select the norepinephrine. Though the sir said dopamine will be the better, but I think norepinephrine will be my choice in view of patient with ACS, and there are chances of arrhythmias with the dopamine. So I will select the norepinephrine as a pressors of choice.
Okay, and how do you want to start norepinephrine now?
Norepinephrine. You want to ask the dose or this thing? I
Yes,
will start with the.
No, you are asking your bedside.
I will not decide the dose. I will see the hemodynamics. I will start with the low dose and titrate according to the hemodynamics.
Okay. How many mLs per hour should I start? If I am adding 1 ampule of norepinephrine, 2 milligrams in 50 ml.
Mm-hmm. So I will start with 2 ml.
Mm-hmm.
And I will titrate accordingly.
So you have started, now this is the situation.
So I will increase the dose. What is
increase the dose of what? You can tell your sister what to do.
No, I will monitor the urine output now.
Sister, what is the
urine output is coming or
last
not?
1 hour, how much is the urine output?
Last 1 hour, 25 mLs.
25 ml urine output is there.
Still he is hypoperfusing. I will try to increase the BP.
How will you increase the BP? You have to tell the sister what she has to do.
Now MAP is adequate. It's around 80.
Okay.
So look like line is damp slightly. I will check with that.
Mm-hmm.
Whether the arterial line is working properly or not.
Okay. Damping issue is not there. Okay. Reading from the monitor, what do you infer from the ECG?
Still there is a ST elevation. So as early as possible, I will take this patient to the cath lab so that there will be early revascularization.
Okay, especially immediate post cardiac arrest, if there is an ST elevation, you have to order for a 12 lead ECG
Bedside nurse, you are supposed to just administer his drugs.
Okay,
He is
fine.
the doctor. You cannot advise him. Sorry.
Fine.
Yes, sir. Basically, we will give the loading antiplatelet and all this thing. After that, because that patient was ventilated and everything, I am assuming that everything was done prior to that loading and everything.
In critical care, there is no question of assuming. Okay, how should I load antiplatelets?
Sorry, sir.
How should I load antiplatelets?
The
What
patient
drug?
is already intubated. We have to give through the RISE tube, sir.
Okay, what drug? What's the dose?
We will give ecosprin and clopidogrel, sir.
Okay, so we will
325 and
more
300 and with
concentrate
a
here
high dose
on,
of atorvastatin.
yeah, because of shortage of time, we'll concentrate here on the hemodynamic part. So BP is still on the lower side. You have started on NORAD. You want to do something else or continue with like that or increase the NORAD?
No, I will increase the noradrenaline.
Okay, you want to increase the noradrenaline again. Okay, so are you okay with this thing?
Now patient is developing bradycardia, sir.
Okay.
So in this case, we can start the dopamine.
You want to start dopamine?
Yeah.
How much dopamine you tell the sister?
I will prepare a dopamine of 200 mg in 50 ml.
And then
Then I will start at the 4 ml.
you want to start at 4 ml.
Yes, sir. Now we started desaturating, sir. So I will optimize the saturation.
So what you have to do? The ventilator parameters are optimized. Yeah, that was optimized. What you have to do? There is desaturation and like hypertension because hope you remember you have started noradrenaline. BP was
Yes,
high, only heart rate was low. You have started a like a moderate dose of dopamine also.
I will try to taper the noradrenaline now, sir, because BP is on the higher side.
So you want to taper it?
Yes, sir.
Okay. So what do you think? What was the reason for like hypoxemia at that point? Jagannath?
Yes, sir.
So what was the reason for hypoxia at that point? Okay, so this was the situation. Now the patient is stabilized. So we have one more topic for discussion. Really sorry that like I know that we can discuss again so many things. So for the time being, we're just stopping for the debriefing. So Jagannath, you have done very well, very good. But few things I wanted to tell you. The main points, especially as far as the vasopressor part is concerned. It is always better to start an noradrenaline. I completely agree with you the way you started noradrenaline. But at the point when the patient's heart rate started coming drastically down, you should have definitely reduced the dose of dopamine, and either you could have started like an adrenaline slowly, or you should have started a dopamine. So when you are starting dopamine, you should have immediately you should have gradually tapered down the noradrenaline. You cannot keep the noradrenaline at the same dose and again start one more vasopressors. So especially in a like cardiac compromised situations, when you increase the BP too much, the afterload will be increasing. Okay, so the heart will have to press against a higher afterload. So that is why you have to always reduce the BP. And this situation, especially a cardiogenic shock or any cardiac dysfunction, when you ventilate and the BP is shooting up, the heart rate is increasing and the saturation is going down. The first thing you have to keep in mind is the possibility of pulmonary edema. If you look at ventilator also, you can see the airway pressures are going up. Sometimes you can see the froth coming out from the tube as well. But always make sure when the BP is high and the saturation is low in the cardiac patient, the first possibility you have to keep in mind should be the possibility of a pulmonary edema. So along with all these things, you should have given a shot of diuretic also at that point of time, which would have definitely reduced the pulmonary edema like in a bit faster way. And one point which I missed in the last discussion, Dr. Joshua was starting like oxygen when the patient was saturating 93, 94. No, you don't have to do that. If the patient is having a hypotension and the oxygen sats are very low, yes, you are justified. Okay, up to 96, fine, but don't try to target a 100% oxygen. That is true with COVID patients also. By hyperoxygenating the patients, you are not going to gain anything. And in these both scenarios, the main thing you both have missed is taking an ABG. So these hypotension and again these cardiac problems all can be because of an electrolyte abnormality. I do admit that the ECG was absolutely normal, but still we will have to always, especially like your bedside nurse told that the urine output is dropping. So you have to check the potassium value, and again it's a post-arrest situation. And the hemodynamic compromise may be all because of a acidosis getting worsened. So always check a ABG and make sure that the ABG is perfect or there is no severe acidosis. Okay. Anything else you want to add, Jagannath?
No, sir.
Okay, so excellent, Jagannath. Yeah, I think we will have to add one more panelist. Sir, we have one more scenario, right?
Okay, yeah, one more.
Yeah, we will take Dr. Priyanka Patil. So Priyanka Patil, we are promoting you. Okay, Priyanka, can you talk something? Sorry. Priyanka, can you hear me? Okay, she has left. Sorry. So we will take one more person who was raised. We will take Dr. Sumesh.
Om Prakash.
Om Prakash, you are there?
Om Prakash.
Sorry? No, so we will take Dr. Lloyd. So Lloyd will be promoted to the panelist. Dr. Lloyd, can you just unmute yourself and talk? Dr. Lloyd? Dr. Lloyd? Dr. Lloyd? Dr. Lloyd, are you there? Yeah. Can you hear me? Can you hear me? There is some problem with your mic, I think. Yeah, Dr. Joshua, are you there? Lloyd, can you? Yeah, there's some problem with your mic there. I think you have. Dr. Joshua, are you there? Joshua? Dr. Joshua? Okay. Jagannath, you are there now?
Yes, sir.
Yeah, you can continue. Yeah.
Okay. Before going back to my role as bedside nurse, I'd like to add a few points. Like in this cardiogenic shock, we definitely need to consider a possibility of an angioplasty or cath lab interventions, and extreme cases, even we need to plan for mechanical assist devices like IABP. Okay, so inotrope vasopressor is not only about a set of drugs. We should also think about other practical options, right? So we are proceeding to scenario number 3. A 53-year-old lady, non-hypertensive and diabetic for the past 15 years with poor glycemic control with HbA1c of 9.2, early CKD or chronic kidney disease on follow-up. Her previous non-creatinine was 2.1 and urea was 35 milligrams per cent. Presents with the drowsiness and difficulty to breathe. She has obvious cellulitis on her left leg extending up to knee, and she gives a history of fever since 2 days. On examination, heart rate is 110 beats per minute. Blood pressure is 90 by 50, saturating 90% on room air. Breathing at a rate of 20 breaths per minute. ECG shows sinus tachycardia. Labs, hemoglobin of 9.2 gram per cent. Total count 11,000. Neutrophils 88, lymphocyte 10, eosinophil 2. Blood urea presently is 60 and create of 3.4, sodium 135, potassium 5, and blood sugar of 420 milligrams per percent. We are giving all this scenario because the backdrop is always there. Even if we are going to select, we are going to concentrate on selecting an inotrope or vasopressor, but the backdrop is definitely there. In a critical care scenario, we cannot choose one management and forget the basics. Okay, now I think Dr. Jagannath, you can take over the scenario.
The patient is basically poorly controlled diabetes with the cellulitis.
So 1 minute, let me, you can continue.
Yeah. So the elderly patient with the diabetes, poorly controlled diabetes mellitus with the now presenting with the cellulitis and BP is borderline, basically septic shock, sir. So our primary aim, we will be concentrating on the, hello?
Yeah, you can continue.
This patient we will treat according to the surviving sepsis guidelines, sir. Initially, we will take the blood for the investigation like blood culture, then lactate, and we will start the IV fluid and antibiotics, sir.
Okay, which IV fluid should I take?
Sorry?
Which IV fluid should I take now?
I will select the crystalloid, sir.
Which crystalloid you tell specifically. You cannot.
Yes, sir. Okay, okay.
You want normal saline, ringer lactate, or something else? You tell and how much to be infused.
I will select the ringer lactate at 30 ml per kg of the body weight, sir. Around 1 to 2 liter, I will infuse the IV fluid.
So you want to give
I will monitor
2 liter bolus now?
Yes, sir. According to body weight, sir. 1 liter I will give, 1 to 1.5 liter.
Okay. So given. Sister, did you give?
Yeah, I've given 1.5 liters of ringer lactate infused.
But her saturation is on the lower side, sir. So I think we have given too much fluid, sir.
So what you have to do, you tell.
So, sorry, I forgot the baseline saturation, sir.
The baseline
saturation
was 94 when we are starting.
94. Okay. So that saturation was okay, but now saturation is dropping. We might have fluid overloaded her with the 1.5 liter because her creatinine was also elevated. I forgot that 1.2 or 3 something. In this case, we should have given less amount of fluid, sir.
They have already given, but we cannot do anything now. Your sister has already given. What else you have to do from now? You tell.
I will start on oxygen, sir, and I will give the diuretics because I have given too much of the fluid and she might have overloaded. And I will do the chest X-ray, sir, to see whether, and I will do the 2D echo also.
Okay. 2D echo, it is showing like a normal LV, no issues, hyperdynamic circulation. Then what else you want? X-ray, like bilateral, like a slight hycinus is there bilaterally. There is no patch.
I will give the diuretics, sir. There might be a fluid overload because we have given too much of the. Sorry.
How much diuretic you have to tell sister? No, what diuretic?
I will give Lasix 40 mg, sir.
You will give 40 mg bolus?
Yes, sir.
Okay. I give Lasix 40 mg bolus.
Now BP has again dropped, sir. So I will start on noradrenaline, sir.
How much?
I will take 5 mg in 50 ml, sir. I will start at 2 ml, sir.
Okay, I've started at 2 ml per hour.
Yes.
Okay.
I will optimize the saturation also. The saturation is around 84. I will start on plain mass, sir, oxygen with 6 liter O2.
Okay. Face mask with 6 liter of oxygen given. Patient is restless.
Yes. Now still BP is on the lower side, sir. I will increase the noradrenaline, and I will catheterize the patient to monitor the urine output.
Mhm. Okay, catheterized and only 100 ml
Yeah.
came.
And obviously we will give the antibiotics, sir. I will
Antibiotic was
increase.
given already. You told, no?
Yes.
You have given
Yes.
antibiotic.
I will increase the noradrenaline dose, sir.
Okay,
How much
should I
ml is
increase?
going, sister, now?
It's now at 2 ml per hour.
2 ml per hour.
I will increase it to 4 or 5 ml, sir, depending on BP. I want mean arterial pressure above the 65, and there should be adequate urine output. Accordingly, I will titrate the noradrenaline dose, sir.
Sister, what is the urine output now?
Now in the last half an hour, 10 ml came.
So he's still, the BP is on the lower side. I will increase it to 10, up to 9 to 10 ml, and even if it is not maintaining the, I will start the vasopressin.
Okay, how do I take vasopressin infusion?
Usually we will take a 40 unit in 40 ml, sir, and we will start at 2.4 ml according to body weight. But usually we will start at 1.8 to 2.4 ml per hour, sir.
Okay,
I will start at 2.4 ml per hour.
Okay, I've diluted vasopressin 40 units in 40 ml, started at 2.4 ml per hour.
Yes, sir. So still MAP is on the lower side only. Now I can increase the noradrenaline still further, sir.
How much should I increase? It's already 10.
15 ml, sir.
Okay, 15 ml.
Yes, sir. Now I will start advanced hemodynamic monitoring, sir, because still with the noradrenaline at 15 ml and vasopressin, still BP is
We
not.
have Jagannath. This ICU we have only arterial line. There is nothing like advanced monitor. The cardiac output monitor is not there in this ICU.
So I will consider, I will increase 20 to 25 up to 30, 40 ml noradrenaline, sir, because we have taken only 5 mg in 50 ml, sir.
Sister, can you increase to 30 ml maximum
Okay, I've
dose?
increased to 30. It's almost getting empty.
And we are at a vasopressin at 2.4 ml. Still,
Yes.
BP is not maintaining, and we have adequately filled because the X-ray was also showing bilateral haziness, and there was a desaturation after giving fluid boluses. So we need to add something else. Like I will start adrenaline also, sir, simultaneously.
Okay, adrenaline, how many ampules?
Adrenaline, I will take 5 mg in 50 ml, sir. I will start now. BP is still on the lower side. I will start at 5 ml.
Okay, adrenaline loaded and started.
Okay, so now I think BP is getting stabilized.
Yes, sir.
Okay, so now we'll just stop because of shortage of time. Okay. So Jagannath, again, very good. So this is again a scenario where we are dealing with a septic patient. So here's reasonably assess that patient very well. But always in the sepsis, we have to see the source of sepsis, and if possible, the source has to be corrected first. That is emergency. So this patient had cellulitis, right?
Yes, sir.
So you should have called a plastic surgeon or a general surgeon, and should have consulted him immediately, and like whether there is any significant pus collection, or get an ultrasound done in that area and see whether there is a pus collection. The cultures you have sent, all those things sent, but ABG did you send?
No, sir. No.
Yeah, this is the basic thing in any sick patient.
Yes,
We have already discussed that point. ABG is very, very important. Without ABG, like you may not be able to proceed. This patient may be having a severe acidosis, electrolyte imbalance, all those things. So ABG you have to always take. And again, regarding the ringer lactate, especially if your lactate values are too high, like it may not be advisable to start a ringer lactate initially itself, especially if there is a liver dysfunction. So you have to look at other organ parameters also. This patient is already having a very compromised kidney function. And that is a very, very important point here you have to keep in mind. A patient with a compromised renal function, when presenting with sepsis, don't try to give a fluid all on a sudden. This 30 ml per kg and all is a rough estimate when you are working in a peripheral ICU. In a good ICU setup where you have all arterial line, all other measurements, including a bedside ultrasound, give it very gradually. As Dr. Jagannath has clearly mentioned, once he has given the fluid, you don't have any options now. The fluid is already in. You cannot take back that fluid immediately. So you like initially for fluid bolus you can give. Then after that you can give something like a mini challenge somewhere around 100 to 200 ml gradually, like in step-by-step manner. Then see how the response is. And as he was correctly doing, you go with the NORAD, do an ABG, correct any other abnormalities are there, and look at the liver. If liver is compromised, don't go with the ringer lactate. You can go with the other balanced salt solution like a sterofundin or plasmalite or whatever it may be. The same way, if chloride values are too high, don't go with a normal saline because you may be again aggravating a hyperchloremic acidosis. Keep all those points in mind. Another point Jagannath has missed is like whenever you come across a septic shock, even though that is bit debatable, like when the patient is having a refractory hypotension or a resistant hypotension or the vasopressor requirements are significantly building up as we have already seen here, we have to always give a supplementary steroid dose, something like a 200 milligram infusion over 24 hours. It will be again practically a bit difficult in a small ICUs. So start on steroids something like a 25 milligram 6 hourly. You don't have to look at a serum cortisol at that point at all. Okay. Then along with that, you look for coagulopathy, other parameters. You continue fluid resuscitating. And another important thing what we could have done in a better way is like the oxygen. Whenever the patient started desaturating, you have to start oxygen at that point itself. At this point, the patient is already hypovolemic. That's why the moment you given the Lasix, the patient's BP again dropped. So what we could have done at that point would be like you could have started a non-invasive ventilation with slightly higher EPAP. So that would have definitely reduced the pulmonary edema. You give some more time with the non-invasive ventilation, and by that time, usually the patient will improve. So there is the last situation was a cardiogenic shock with pulmonary edema or the cardiac dysfunction with the pulmonary edema. This is a septic patient who is already hypovolemic. And along with these things, like if you don't have an advanced hemodynamic monitoring, so by advanced hemodynamic monitoring, our Dr. Jagannath, he was mentioning about the cardiac output monitors like stroke volume variation or the peripheral vascular resistance, all those things. So if you don't have that, you can do a bedside ultrasound and see what is IVC collapsibility or stroke volume variation. And there are so many other parameters like echo-based hemodynamic monitoring tools could have very well utilized. And the step what he has run is absolutely correct. You start with noradrenaline, then you add on vasopressin. Along with that, you give adequate fluid. Then you, even if it is not getting controlled, you go with adrenaline. But like as Dr. Saneesh was mentioning initially itself, whenever there is a significant lactic acidosis, you start adrenaline, the lactic acidosis can get worsened. So to look at lactic acidosis, the ABG should have a lactate value. Then normally we take it as 2 millimoles per liter. If it is going too high, that means the lactate levels are worsening. That again indicates the tissue hypoperfusion. And you have to always monitor the urine output also. This patient already had a creatinine value high. So other point we would wanted to know at that point would have been like whether this is a chronic kidney disease patient or an acute kidney disease patient. So how to do that? You ask the relatives about the previous creatinine value. So if this patient is already a pre-existing kidney injury patient or a CKD patient, now again coming with a sepsis, the scenario is slightly different. You may not be able to save the kidney sometimes. But if an AKI, probably that will respond better with the fluids and other supportive measures. Okay. So I think with those points, like we'll just, can you just see sir, the Q&A sessions, any other points to be taken? Yeah, ABG, yeah, very good point. We could have done that. All negative blood can be started as early as possible. Yeah, that is a mapping transfusion protocol. Yes, true. We really agree on all negative blood as well. But majority of the good hospitals can get a cross-matched blood immediately, and that patient was not severely collapsing. Which diluent for each? Dr. Kiran is asking. Kiran, I know why you have asked that. There were initial few recommendations to start noradrenaline and adrenaline on 5% dextrose, but now there are very compatibility studies also. You don't have to go with a 5% dextrose. Even a normal saline is a good choice. So in our ICUs, we go with normal saline. Positioning of the patient to avoid aspiration of blood into his lungs. In a very sick patient, when you are dealing with, sometimes it may be really difficult. If the patient is extremely drowsy, or like the drowsy patients, you are taking for a endoscopy or hemodynamically compromised. The only way by which you can prevent aspiration will be you secure the airway. So here the patient was not that drowsy. Other than that, the position, even though you can keep the patient straight, keeping in the left lateral position and all, may be possible in an emergency situation, but not very practical in an ICU situation. Yeah, bedside ultrasound, IVC, all those points are well taken. Those other patient has pulmonary edema, fluids. Yeah, this patient, we can start with fluid. We have already discussed. We will always see the other possibilities also regarding the fluid management. And yeah, you have to, yeah, very good point. Deepa has like pointed out a clear-cut point. Here the sugar was very high, 480. So you have to specifically look for, Saneesh said it was 480, right?
Yeah,
Yeah.
420.
You have to specifically look for ketoacidosis and again urine ketones or serum ketones if you want. And again look at an ABG, and if there is a wide gap anion gap, wide gap acidosis, obviously that again pointed out. Urine ketone, excellent. Yeah. Really sorry that I missed that part. Rule out DK. Yeah. The infection. Yeah. Everybody was mentioning that. Very good. That's a you all are listening well. That is a valid point. And again, sorry that I also missed that one. So, I think you understood like how to titrate the vasopressors and how the situation progresses. So, thank you, Joshua. Thank you, Jagannath, and again, thank you, Lloyd, and others for joining us. And now we will move on to Dr. Fabian Morir for his excellent presentation. I'm really sorry that we are already running late. Almost, it's I think 1.5 hours over. But I think you will be listening to Fabian. I am sure, because you are going to get a more excellent presentations with the videos, and he will also will give you notes on these things in the like our group. So, Saneesh sir, how can we share the notes and presentations to all the participants? Any site?
Yeah, maybe we can have a PDF version and
Sharing to all the persons will be difficult. Again, adding everyone to WhatsApp.
Mhm.
So is there any other option? Like, can you put it in your site?
Yeah, sure.
So can you just
Maybe I
type
can upload it to my website.
Can you just type here in the like chat box your this thing in the chat? Here in the chat you can type.
To all panelists, no?
Yeah, chat. So please visit this website. You can give your number also, and daily we'll be updating that website. And again, my Facebook account I've given yesterday. So in my Facebook account also, we will be putting the schedules every day. And obviously, I've already given my mobile number yesterday. I'm again typing here. So I will try to include everyone there. So this is my 9961085558. So if you WhatsApp, I will add you to the group, and again I can share you all the details, and again I can give you the the information regarding further classes as well. So yesterday also I was getting so many messages, so it was a bit difficult for me. But please, here Dr. Shah, like if you type your messages here, it will be a bit difficult for me to take from that. So just put it in my personal WhatsApp, or like you can put it in Dr. Saneesh website, or this is the website like onlineanesthesiatools.com. So in that website, you will be like putting these things, and probably this video also we will try to put there. Okay, www.onlineanesthesiatools.com. Okay, yeah. And